Hello, I am Dr. Brian Gulak from Duke University Medical Center, currently a PGY2 resident at the Department of General Surgery, and I'm here today to present shock, complex yet simple. In summary, there are multiple types of shock, all of which have many similarities, but also many differences. The successful clinician must be able to recognize these signs, know how to begin the workup and treatment, and how to guide future therapies. The data surrounding the best treatment strategies for shock is constantly changing and requires regular revision. Shock has historically had many definitions. It was initially described as hypotension. However, today, it is more thoroughly described as a malfunction of total body cellular metabolism. It is perhaps best to think of it as an imbalance between oxygen supply and oxygen demand. When the body cannot supply enough oxygen to cells to meet demand, cells enter an inflammatory phase which causes the effects of shock. This includes not only cell death, but the release of cytokines that promote systemic dysfunction. There are 5 different types of shock that I'm going to talk to you about today. The first of which is hypovolemic. This is the most common and most often due to hemorrhage. The second is cardiogenic. The third is septic. The fourth is anaphylactic. And the fifth is neurogenic. Before I begin, I think it's useful to simplify the idea of shock. If you look at the screen, you'll see that blood flows in a common pattern through the systemic system. There are 4 different parts of the system. There's the heart, which is the pump, the arteries, which are the afterload, the cells, which are the capillaries, and the preload, which are the veins. Shock can occur due to a loss of function at numerous different spots along this circle. If there's a loss of preload, i.e. blood's not getting back to the heart, i.e. in hypovolemia, that can cause shock. If the heart does not work and does not pump the blood forwards, as in cardiogenic shock, that can lead to shock. If there's dilation of the arteries and afterload, that also will cause a loss of blood pressure to the cells and will also lead to shock. Therefore, you can see numerous different aspects in the body can lead to shock. Hypovolemic shock. Like I said before, this is the most common cause of shock. It's most commonly caused by hemorrhage, which you'll often see in the trauma situation or post-operatively. The largest cause of shock with regards to hypovolemia is a decreased return of blood to the heart, therefore decreasing cardiac output. The amazing human body responds very interestingly to hypovolemia. The carotid baroreceptors notice the loss of pressure and therefore increase the sympathetic tone to the body. This increases the heart rate and constricts peripheral blood vessels, increasing the blood pressure and shunting oxygen to vital organs. The different types of shock are often characterized by whether they cause the extremities to become warm, think of vasodilation, such as septic shock, or cold and clammy, think vasoconstriction, such as in hypovolemic or cardiogenic shock. Hypovolemic shock comes with certain signs and symptoms. Tachypnea, which is increased respirations, tachycardia, increased heart rate, like we said before, and agitation are often parts of these symptoms. You'll find that you'll often be called late to the floor when you are a resident for a patient who's agitated, and in your differential you must think of things beyond the normal agitation causes such as delirium or dementia, and consider could the person be in hypovolemic shock. It is very important to note that a patient may not even become symptomatic from hypovolemic shock until at least 20% of their initial blood volume is gone. Although it is out of the scope of this presentation, it is important to learn the different stages of hypovolemic shock with regards to blood loss. In the initial stages, the body enters a compensated hypovolemia, in which blood pressure may be kept within normal ranges by other mechanisms that we've talked about earlier, such as increase in heart rate and vasoconstriction. Eventually, as the body continues to lose blood, it'll enter a decompensated shock, in which the compensatory mechanisms cannot keep up with the loss of volume, and hypotension will result. There are numerous different laboratory aids that can help in the diagnosis and management of hypovolemic shock. Notably, as a cell enters an anaerobic metabolism, they produce lactic acid, leading to a lactic acidosis. Lack of preload to the kidneys will also cause BUN and creatinine elevations. Furthermore, if the patient has invasive monitoring in place, a drop in central venous pressure or pulmonary artery occlusion pressure may be seen. Lastly, the patient's blood concentration will drop. It is important to note that hemoglobin and hematocrit are not absolute values of blood volume, but are in fact concentrations. So in the early stages of blood loss, these may still be normal until fluid re-enters the blood vessels, causing a drop in the concentration. The goal of treatment in hypovolemic shock is to restore circulation as well as to correct the etiology of hypovolemia. Initial resuscitation should focus on the use of a crystalloid solution. Most trauma surgeons advocate the use of lactated Ringer solution, as normal saline is in fact acidotic, and in a patient who is already becoming acidotic because of hypovolemic shock, this may make matters worse. If necessary, transfusion with packed red blood cells should be undertaken. Most surgical teaching focuses on the use of blood if necessary when a patient does not respond appropriately to 2 liters of LR. Although fresh frozen plasma, or FFP, is not recommended for resuscitation purposes, it may be necessary to correct coagulation deficiencies in patients requiring massive transfusion. This is because as patients obtain large amounts of fluid, their coagulation factors actually become less concentrated in the blood, leading to coagulation issues. Platelets and cryoprecipitate should also be given during massive transfusion for these same reasons. New data has shown that in selected patients, restricted fluid resuscitation is useful in order to prevent dilution of these important coagulation factors. It is also important to keep these patients warm, as even mild hypothermia causes coagulation dysfunction. If necessary, the use of ionotropic medications, also known as pressors, may be necessary. Throughout this discussion on shock, we'll be talking about the endpoints of resuscitation. In each type of shock, there's going to be a point in time when you can successfully say that you have finished resuscitating a patient. However, for each different type of shock, these are different. With regards to hypovolemic shock, there's unfortunately no clear evidence for one single valid endpoint. Some recent data has shown that even heavy fluid resuscitation can actually be detrimental and should be tailored to maintaining a palpable pulse and mental status until the predisposing cause of the hypovolemia, most often hemorrhage, is controlled. Despite there being not one single endpoint of resuscitation for hypovolemic shock, most physicians agree that a number of factors should be considered. These include a normalization of the patient's pH and lactate. If you remember, when a patient is hypovolemic, their cells starve for oxygen and produce lactate as a response, causing a lactic acidosis, so you get a drop in pH. A normal venous oxygenation. When a patient is in a state of hypovolemic shock, oxygen cannot be supplied to the cells, and therefore the actual venous concentration of oxygen drops. A normal cardiac output. Remember that hypovolemia causes a decrease in preload to the heart, and therefore if the patient has enough blood getting to the heart, their output should respond. Normal urine output. This is documented as more than 0.5 cc's per kg per hour. And a normalization of vital signs. Moving on to our second type of shock, we're going to talk about cardiogenic shock. This is a disruption of normal cardiac function, also known as pump failure, if you remember from my diagram earlier, which can be caused by numerous etiologies, including ischemia, acute valvular disease, arrhythmias, and cardiomyopathies, among others. Although not always considered cardiogenic shock, in older textbooks this is sometimes referred to as obstructive shock, there are 3 different pathophysiologies that every medical student and resident should be aware of that lead to a cardiogenic type of shock. All of these lead to an increased pressure in the mediastinum where the heart sits and decreases the venous return to the heart. The first is pericardial tamponade, which is fluid building up around the heart in the pericardium. The second is a tension pneumothorax, where air is entering into the pleural space but cannot escape, causing an increase in pressure. And the third is an increase in abdominal pressure, which also decreases blood return back to the heart via pressure on the inferior vena cava. The diagnosis and treatment of these mechanisms is unfortunately outside of the scope of this presentation, but they are important to learn in order to recognize and treat them effectively should they occur in your patients. Cardiogenic shock also comes with some specific signs and symptoms. hypotension, like we've seen in all types of shock, tachycardia or bradycardia, as the heart can either speed up to try to make up for its lack of output, or sometimes, depending on the etiology, will slow down, tachypnea, and very importantly, and differentiating it from hypovolemic shock, is JVD, or jugular venous distension. In this picture on the right, you can see where the arrow is pointing to distension of the patient's venous system, representing the fact that fluid is actually building up before the heart, i.e. pump failure. Other signs of increased preload to the heart can also be present, which includes pulmonary edema, aka fluid building up in the lungs, lower extremity edema, and liver failure. There are numerous laboratory and radiologic aids to help you diagnose cardiogenic shock. These include chest X-ray, which can demonstrate pulmonary edema if fluid is backing up into the lungs, an increased central venous pressure, or PAOP, pulmonary artery occlusion pressure, increased BUN or creatinine if the cardiogenic shock is leading to a renal failure. Very importantly, and as you see here on the left in 3D, echocardiogram, which will demonstrate abnormal movements of the heart depending on the etiology of the cardiogenic shock. And once again, SVO2, or systemic venous oxygen saturation, which will be decreased as the body will not be able to supply the oxygen to the cells due to the cardiogenic shock. Treatment. Cardiogenic shock, it's very important to note, compared to hypovolemic shock, responds very differently to fluids. A patient in hypovolemic shock is fluid behind and needs fluid for resuscitation. A patient in cardiogenic shock may actually be hurt by these fluids, as they'll back up into the lungs, causing pulmonary edema and hypooxygenation, along with other places in the body. Therefore, in cardiogenic shock, you should only be given fluids if necessary, but otherwise, treatments should focus around the treatment of arrhythmias if present, or through the use of inotropic drugs, mechanical support, including intra-aortic balloon pumps, or IABP, and surgical intervention, including CABG, coronary artery bypass graft, and ventricular assist devices. We'll now discuss septic shock. Septic shock is normally thought of shock related to infection, but it's very important to note that there are certain definitions that everyone should be familiar with. The first of which is bacteremia. Bacteremia, by definition, is documented bacteria in the bloodstream. This can come along with other signs and symptoms, as we'll discuss, and be called other things, but alone, in a patient who's not having an inflammatory response to it, is just called bacteremia. On the other side, you'll see SIRS, S-I-R-S, or Systemic Inflammatory Response Syndrome. This does not need to come with bacteremia, but can, and as you'll see, will move up to being sepsis. But SIRS alone is something that can occur without an infection. Every medical student resident should be familiar with the definition of SIRS. To have a patient in SIRS, you need to have two of the following four. The patient must have a temperature greater than 38 degrees Celsius or less than 36 degrees Celsius. The patient's heart rate must be greater than 90. The patient's respiratory rate must be greater than 20, or a PaCO2 less than 32. And the patient must have white blood cells greater than 12,000 or less than 4,000, or have greater than 10% bands. When you have SIRS, along with either a documented or suspected source of infection, that brings us to sepsis. When you have sepsis along with organ dysfunction, that brings us to severe sepsis. And when you have sepsis with hypotension requiring inotropic drugs, despite adequate fluid resuscitation, we've now entered into septic shock. Septic shock has numerous causes. The most common postoperative infectious cause of death, which will eventually present with septic shock before death, is pneumonia. Urinary tract infections can become pyelonephritis and lead to septic shock that way. Catheter-related infections, most importantly, catheters used for central venous access, both for medications and also for dialysis, can lead to septic shock. C. diff, also known as Clostridium difficile, can actually lead to septic shock. And intra-abdominal catastrophes, such as post-surgical issues like anastomotic breakdowns or abscesses, can lead to septic shock. The signs and symptoms of septic shock include mental status changes, warm skin. This is different than hypovolemia and cardiogenic shock when the body is going to vasoconstrict in order to keep pressure up, because the inflammatory response to the bacteria includes vasodilating. Patient will also become tachycardic as the body tries to compensate the vasodilation and drop in blood pressure, and will often have a fever associated, although the fever may come and go throughout the course of the disease. Laboratory aids will also demonstrate either an increased or even decreased white blood cell count, which can be seen in severe shock. A lactic acidosis can often be present, and or a decreased central venous pressure due to decreased preload to the heart due to the vasodilation. Interestingly, blood glucose is intimately involved with septic shock. As cells enter a state of dysfunction, they stop using glucose properly, causing an elevation in serum glucose. In fact, a patient with a sudden increase in blood glucose with no other underlying etiology should be suspected of being in early stages of sepsis. Lastly, SVO2, or systemic venous oxygen saturation, once again makes an appearance. Unlike in hypovolemia or in cardiogenic shock, the SVO2 actually increases in septic shock, secondary to the fact that as the cells enter a state of dysfunction due to the inflammation they're going through, they lose the ability to use oxygen properly, and the venous side of the circulation sees a higher oxygen concentration. With regards to treatment of septic shock, unlike other forms of shock, there is actually high-quality evidence that early goal-directed therapy, now those are key words for all med students and all residents to know, in quotes, early goal-directed therapy decreases mortality. There are now certain intensive care guidelines called Surviving Sepsis, which were reviewed regularly, that all intensive care practitioners and medical students should be intimately aware of. The Surviving Sepsis guidelines are compiled by an international committee on a regular basis. There are certain important goals of treatment that everyone should be aware of. The first is keeping a central venous pressure documented by a central line, such as an IJ or a subclavian line between 8 and 12. A MAP, or mean arterial pressure, greater than 65. A urine output greater than 0.5 milligrams per kilogram per hour. A SCVO2 or SVO2 greater than 70% or 65%, respectively. Just to clarify, SCVO2 is central venous oxygen saturation from a central line, whereas SVO2 is the mixed venous oxygen saturation from a pulmonary artery catheter. Lastly, broad-spectrum antibiotics should be given within 1 hour of suspected sepsis. Fourthly, we're going to discuss neurogenic shock. Neurogenic shock is a little bit different than the rest of the shocks we've talked about, in that it's actually caused by a neurologic issue. Following spinal cord injury, autonomic dysfunction can lead to death in both the acute and chronic stages. This is due to both an effect on the heart, which can lead to bradycardia inappropriately, as well as low blood pressure due to loss of tone in the peripheral blood vessels. Neurogenic shock is different from spinal shock, which is a loss of reflex functions, including those in the cardiovascular system, but these tend to resolve within 6 weeks. Treatment also tends to be a little different than the other shocks we've talked about. Once neurogenic shock is recognized, it is important to realize that the patient will not respond well to continued fluid resuscitation and will actually overload. There is no current evidence, unfortunately, as to proper endpoints of fluid resuscitation in neurogenic shock. However, once it is felt that adequate fluid resuscitation has been obtained, the patient should be on inotropic medications, also known as pressors, with both alpha and beta activity to prevent bradycardia and maintain adequate blood pressure. Lastly, we're going to discuss anaphylactic shock. Anaphylaxis occurs after a trigger sets off a biochemical cascade leading to basophil and mast cell activation. There are numerous systems involved, but the respiratory-cardiovascular system effects can be the most dangerous. An iatrogenic anaphylaxis, aka anaphylaxis caused by us, the average time from trigger to respiratory or cardiovascular compromise is only around 5 minutes. Once diagnosed, the initial treatment of anaphylactic shock focuses on the use of histamine antagonists, also known as antihistamines, and steroids. However, once anaphylaxis progresses towards cardiovascular or respiratory collapse, supportive care, including airway protection and cardiovascular support, think inotropic drugs, becomes integral. Epinephrine is also indicated in suspected anaphylaxis due to its alpha-1 activity and beta-2 activity. Alpha-1 is useful in keeping the blood vessels constricted. Beta-2 is important in bronchodilation. Unlike in code scenarios, this epinephrine is often given in subcutaneous doses and not IV in the outpatient world, as you may be familiar with EpiPens. In conclusion, there are numerous different types of shock, and although all are called shock, they are very different in their causes, the way they present, and how they should be treated. Their similarity is in regards to how they affect cellular function. The modern clinician should be able to diagnose shock, determine its cause, and know how to properly treat it. Thank you very much for your time.